Not just for thinking about it. That's funny.
Thank you.
Ready? Okay, let's call the November 14th Medical Services Board meeting to order. And Judy, if we could start with roll call, please.
Christy Blakely.
Present.
Timothy Fox.
Here.
Patricia Gibbons.
Here.
Brigida Hughes.
Present.
Brenda Lacombe.
Here.
Paul Milankovich is excused. Amanda Moore.
Here.
Jenny Riley.
Here.
Donna Roberts.
Present.
Mike Stahl.
Here.
Mary Young.
Here.
We have 10.
Great, thank you very much. General announcements, the date and location of the next Medical Services Board meeting. The next meeting is scheduled to be held on Friday, December 12th, 2014, beginning at 9 a.m. here at 303 East 17th Avenue, Denver, Colorado, in the 7th floor conference room. It is a policy of this board and the department to remind everyone in attendance that this facility is private property. The capacity of the meeting room is 80. Please do not block the doors or stand around the edges of the room, and please turn cell phones off while in the meeting room as they interfere with the recording equipment. Two other quick additions to that is that we have limited external mics here, so for Mr. Fox to be able to hear us, I'd ask everyone to really speak loudly as well as into your microphone so we can make sure that's heard. And if you're listening via the audio stream, you'll have a better listening reception if you use headphones versus external speakers, is what I've been told. So go get your Dr. Dre Beats out and have fun with that. We're going to start with the approval of the minutes of October 10th, 2004 meeting. If I could have a motion.
Mr. President, can I make an addendum to those minutes?
Sure.
And just add my name to the members present from the meeting last month.
Thank you. With that amendment, do I have a motion for approval?
I'll move.
Second.
Got a motion and a second. All those in favor of approval of October 10th meetings, please signify by saying aye.
Aye.
Aye. Mr. Fox?
Aye.
Great. Thank you very much. Before we jump in the rule portion, we're going to jump into our budget and legislative update to allow folks to get back to the Capitol and stay updated with what's happening. So we have Josh Block and Zach Linkowitz here to present.
Very good.
Mr. President. Good morning. My name is Josh Block. I'm the Budget Director for the Department of Healthcare Policy and Financing. Joined here by Zach Linkowitz, our Legislative Liaison. Today we're going to talk a little bit about our budget package that we released on November 1st, or actually November 3rd, which was the Monday, on our legislative agenda coming up here for the upcoming session. First time I've given this presentation this year, so please excuse me if I stumble over it a little bit. Still also trying to warm up as temperature starts rising here. By way of introduction, Healthcare Policy and Financing is the largest state department by appropriation. We are about a third of the total state budget. We are at $7.9 billion. The next highest budget is less than 5, and that's education. We're also about 26% of the state's total general fund. We're second place, and that education does have about $3.5 billion. Interestingly, we also obtain about 65% of the federal funding that Colorado receives, over $4.6 billion in that regard. We're also growing. This year we're going to cover more than 1.1 million people in Colorado, and that is more than 1 out of every 5 Coloradans. Our budget request this year is a request for $714 million total fund. Of that, however, only $176 million is general fund. I say only, which is a strange word to use with general fund, or rather for $176 million. Most of that increase, however, is due to caseload, and in particular, it's due to the expansion that the state authorized under Senate Bill 13200, which is the Medicaid expansion permitted under the Affordable Care Act. Our caseload growth continues even as our economy recovers, and to cover our caseload and our obligations under Medicaid, we're requesting $653 million total funds. That's of our 714 total, of which $160 million is general fund and $450 million are federal funds. We plan most of this increase is due to caseload growth, as I mentioned. And this year we'll be covering approximately 225,000 adults without dependent children who are not previously eligible for Medicaid prior to the expansion, and also close to 100,000 new parents and children, many of whom were previously eligible but were not enrolled in Medicaid and have shown up because of the insurance mandate and the growth and or the expansion. The outreach efforts that have been placed both by this department and also Connect for Health Colorado. An important note as part of our budget request this year is we're also allowing for growth in our waiver programs for intellectual and developmental disabilities. And in particular, we're going to be maintaining the policy of having no wait lists for the home and community-based services waiver for supported living services and the children's extensive support waivers. We received funding from the Joint Budget Committee and the General Assembly over the last 2 years, and we're going to continue to request funding to make sure there's no wait lists on those programs until they tell us to stop. In addition to that, we're also including some increased enrollments for the home and community-based services waiver for individuals with developmental disabilities. In particular, those enrollments are related to people who need emergency or time-sensitive placements. That's a continuation of the past policy, but it's rolled up a little bit differently in our budget this year. But there's no change to making sure that those folks can get served when they need to. The remainder of our budget package is what are known as discretionary items, or the things that aren't necessarily driven by caseload or cost per capita. And our budget request this year really is about better serving our clients. As we have, like I said, almost 1 in 5 Coloradans, we have to make sure that we're doing the right things in terms of, and like this first request, making sure that people have as much continuous coverage as possible. We refer to that as reducing churn, and churn typically refers to people moving on and off the program. We already have a policy of continuous eligibility for children. That isn't really possible for adults. It's not actually an option on the federal level without a waiver. And so to combat that, what we're trying to do, and what we're requesting of the Joint Budget Committee and the General Assembly, is to change the way that we determine eligibility for adults. And in particular, we want to use an annualized version of income instead of monthly income. Right now, our income determination is based on a client's monthly income, and so that causes a lot of, again, churn, while people, particularly who have high seasonal income, they may suddenly have income in 2 or 3 months out of the year, lose Medicaid eligibility, have to change coverage options, and then come back to the program 3 or 4 months later. We want to reduce that because coverage gaps lead to poorer outcomes, but we're still going to have flexibility to account for recent changes in a person's life, such as if they lose their job or have some other type of qualifying health event. In addition, as part of that request, we're also requesting to to provide a 1-month grace period on enrollment fees for the CHIP program. Right now, folks who are applying for the CHIP program have to pay an annual enrollment fee, and you don't currently get services until that enrollment fee is paid. Most of the time, the delay there is because it just takes time to process things. It's not because clients are not paying us, and so what we'd like to do is provide the 1-month grace period to allow them to get coverage as quickly as possible and still give some time for the process to account for the payments that they've made, and make sure that clients get the services faster and when they need them.
If I could just jump in, just to make things challenging for you, I gave you a handout with our budget requests. The order in which Josh is talking isn't necessarily the order in which your handout is, so that's just an FYI.
It's important that we challenge you this morning. Get you guys off
we
light.
appreciate that.
It's a nice warm-up for all the rules that are coming.
So this one is the Medicaid and CHIP enrollment simplification. It's at the bottom.
The next request we have is expanding or enabling a participant-directed service delivery option in the home and community-based services waiver for supported living services. This is also on the first page, second header, I think. As many of you know, consumer direction has been a longstanding issue for the department. It was initially authorized for all Medicaid waiver programs back in the 2005 bill. However, because of the price tag related to it, we've only been able to expand it to, I believe, 3 of our waivers at the moment. This would be the 4th that has it. In addition, as part of this request, we also want to support the Community First Choice Council, which is a group essentially tasked with reforming Colorado's home and community-based services system by making some technical adjustments, moving Colorado from a series of waiver programs to a more robust state plan benefit. There are a lot of challenges related to that. In particular, it has the potential to cost a significant amount of money, so we're requesting money to help identify what the cost is going to be there and to support the council in terms of getting ready to provide a bill to the General Assembly to implement that option. on, now I'm trying to.
I'm sorry,
Fine, no,
this is my fault.
I appreciate you taking blame for that, Zach. Our next request is about our Children with Autism waiver program. Right now, we have a waiver program where 75 clients can receive services, and we have a waiting list of about 300 children who qualify for services but do not receive them. This is incredibly important as recent findings from the CDC, I forget the acronym for the CDC, it's still early. The CDC has done studies showing that the prevalence of autism has increased. And so what we want to do is we want to make sure that these children are getting served. So we're requesting funding to fully eliminate the waiting list for children with autism. We're going to do that by reducing the balance in the Children with Autism Treatment Fund this year. It's a program or a cash fund that receives $1 million a year, and using general fund to account for the difference there. Our next request involves providing access to personal health records for Medicaid clients. Last year I came and talked to this board about providing funding around health information exchange and allowing information to flow back and forth between providers to ensure that we have a more coordinated framework around medical services. This year we're taking another step in that direction by trying to make sure that information about what services clients have received is available to those clients, and make sure that people have access to what services they're receiving, and also provide an online health repository of information that clients can use to take charge of their own health. So we're really excited about that, and our ability to sort of leverage technology related to our new MMIS, this new health information exchange. We're also, as part of this budget request, requesting money to participate and fund the Comprehensive Primary Care Initiative, which helps providers within practices talk to each other and continue the work again to help normalize costs across the system. We know that there's a lot of variation between not just different healthcare providers, but within the same practices. And so we're looking to help make sure that that information is shared and providers can make better decisions or more consistent decisions about the services that they provide. One of the things that we found, switching topics here, with the Affordable Care Act is that the large increase in caseload that we've experienced has quickly overwhelmed our ability to provide customer service to clients, and in particular around eligibility issues where they need to call us up and find out what's going on with their application, make sure that they can get, or find out how to make sure that they're getting benefits and answer the questions that they have. With over 1.1 million people on Medicaid, we need a large division of customer support staff, and currently we have a very small one. So the request here is something a little extraordinary for us. We're requesting 25 new staff members to fully staff our customer support division. And that would enable us to get up to industry call center standards. Right now, people are currently waiting for hours, if they can get through it all, to get service, and we can't have people waiting on the phone all day, every day, to find out information about what's going on. We're also going to use this funding to help better enable some more technologically robust items, things like live chats online or email access and things like that. In addition to that type of the client experience, we also want to provide some funding to local public health agencies. Local public health agencies are unique in terms of, or the public health mission in general is a little bit different than the Medicaid mission, where we are there seems to be a divide between the missions, in that public health agencies tend to work around the entire state and without necessarily regard to whom they're serving, while Colorado has a robust framework around, our department has a robust framework around providing services to Medicaid clients. But the fact is, there isn't that much of a gap between what's going on. We need Medicaid clients to be connected to primary care services, and local public health agencies are very good at doing that. So what we want to do is we want to provide funding to local public health agencies in the form of grant funding, so we'd like them to come to us, and working with our regional care collaborative organizations inside the Accountable Care Collaborative to come up with ways to use this funding to better connect Medicaid clients with primary care services in a way that is coordinated and in particular local, so it's not the state dictating solutions to organizations around the state, but more from the ground up, so we can make sure that we're meeting clients where they need to, or where we need to find them. Speaking of the Accountable Care Collaborative, one of our other major issues here is reprocuring the Accountable Care Collaborative. We began this program back in 2009 through the budget process, and it has grown to cover approximately, as of last month, over 720,000 Medicaid clients. So it is the most important delivery system we have here It touches 3 out of 4 Medicaid clients, essentially, and it's still growing. The contracts for the RICOs, the Regional Care Collaborative Organizations, are competitively re-procured, and so we're required to re-procure them every 5 to 7 years. Before we embark on that, however, we want to make sure that the ACC is covering what it needs to. And so we want to make sure that the regions are properly aligned with what we see. We determined that once 5 years ago and need to make sure that it's still the right thing to do. We need to determine whether or not we can make the program better, and we want to solicit impact about that. And we want to make sure that we're properly moving down the path of integrating behavioral health services and other health services to ensure that clients get a more coordinated framework or a more coordinated healthcare experience.
May I ask a question about that?
Yes, Mary?
Sorry.
Jump in there.
When it says here integration, including behavioral health integration at both the system level, what does that mean? System level versus the point of care level? What's the vision of that?
Thank you, Mr. President, Mr. Dudion. Right now, our behavioral health program is run by a completely different set of providers. Mm-hmm. Right, we have the behavioral health organizations, and we pay them separately for mental health care, and so, or for behavioral health care. Make sure I get the terminology right. The goal here that we have is to ensure that even though these are disparate systems, that clients are receiving, that clients don't have to jump between providers to get behavioral health needs addressed. And we've seen a lot of steps in that regard in terms of co-location of providers and things like that. But our goal is to make sure that there is a more robust and less ad hoc system. It won't change who delivers the services. However, we want to make sure that clients are, that we don't have to send clients between providers and say, oh, that's a behavioral health issue, you're going to have to go somewhere else to start to get that need addressed.
Thank you.
In addition, staying on the behavioral health topic, one of the things that we were funded last year with the increase in revenue from marijuana sales was providing substance use disorder treatment and services in schools. And we do that through the behavioral health programs. We requested that funding last year, approximately $5 million to do that. We want to continue that program. It was initially appropriated as one-time funding, but we know that preventing substance use is important things, particularly for children, particularly with the advent of marijuana and continuing with other substance issues, alcohol and other drugs. We want to make sure that schools have the right sort of resources that they need to provide services to clients timely. If we wait till clients have an issue and they show up in a hospital or a doctor's office, we're probably too late, and it's going to end up costing us money and provide poor outcomes for clients. So we want to continue to make sure that schools are being funded for that. We also have a request here to increase the amount of funding that we are providing to schools for other services as well. We work in coordination with school districts to make sure that certain Medicaid services are provided to a particular set of clients, particularly those with individualized education plans, if I remember the terminology correct, which is typically for individuals who have developmental disabilities or delays or other related conditions to that. And then finally, we are also looking for money to ensure that we continue to be good stewards of taxpayer dollars, and in particular, we're looking for funding to do periodic reviews of financial statements by managed care programs and also primary care fund recipients. We have recently received a notice from the OIG. We saw an audit in other states that there were certain programs that were accounting for unallowable administrative costs, in particular inside of capitation payments, which is the monthly payments we make to managed care organizations. And then again, in particular, with the primary care fund, where we have a limited amount of money to provide to providers, we need to make sure that that money is being spent on allowable activities, and the information that we receive from providers is accurate to determine how we break that up. That is the abbreviated version of our budget request. Only took about 15 minutes or so, and thank you for your patience on that. With that, Zach will talk a little bit about our legislative agenda, and then we'd be happy to take any questions you have.
Great.
Yeah, so again, my name is Zach Linkwitz. I'm the department's new legislative liaison. Thrilled to be here. Unfortunately, I don't have a ton to talk about. We were cleared by the governor's office to go and find sponsors yesterday. So the one bill that we do have that I can't talk about today, and I'm happy to talk about the other two in December once I have sponsors secured. The one bill Josh already talked about, it's the elimination of the children with autism waiver wait list. There's a statutory enrollment cap the age limits in statutes, so we need a statute change to take that age limit up to 8. There's also a few other components of that bill. So it increases the age limit to 8. It eliminates the 75 limit cap on our estate plan amendment. It guarantees children 3 years of service even if they get on after age 5. So even though the age limit's to 8, if you get on at 6, you're at least 3 years of services, so you can actually technically go above age 8. And then it increases their service limits by $5,000 per year to $30,000, and it allows that cap to fluctuate. And what that allows us to do as a department is to increase those provider rates, because those providers that have been serving the waiver have not been part of the rate increases for the past 2 years because there's a cap on those services. If we were to increase the rates, the children would receive less services. So I'm personally really excited about that. We're hoping this will be a joint budget committee bill. So far, so good. But we need all 6 members, and right now the joint budget committee is not fully formed. So I've been meeting with joint budget committee members, and will continue to. If the joint budget committee, if I don't have 6 votes on the committee, I'll move it forward as a separate bill. But we're very excited about this, and happy to talk about the other 2 bills next month when I have a little bit more information.
Which will the other 2 bills be?
So I'd like to secure sponsors before I announce them publicly, and we have a little bit more stakeholder work to do before we sort of go full-fledged public on them.
Okay. All right. Thank you.
Mr. President, I have one thing to add, if you don't
Yes.
mind. I can't believe I forgot this in my bit of a speech here, but I neglected to mention that we are also requesting provider rate increases again this year. I suspect some people might be interested in that. Given the state's revenue situation at this point, we are requesting a 0.5% rate increase across the board, so a small amount to help try to keep pace with inflation, but also funding equivalent to another 0.5% rate increase for targeted services. And this is similar to what we did last year, where what we want to do is make sure that we have funding to, or we provide targeted rate increases to make sure that, let me go back to my notes here, to make sure that we find areas where reimbursement issues are preventing access, where providers are saying that they're not going to participate if we don't adjust rates, or we're having difficulty connecting providers to services because of our reimbursement. That's always a challenge with Medicaid, as our rates tend to fluctuate only when we get appropriations to change them. And so we have to make sure that within these appropriations, we're targeting those services that are really problematic and making sure that clients continue to have access to services like specialty care and drugs administered by physicians, eye care, you name it. And so we'll be reaching out to stakeholders this month, here in the next couple of weeks or so. We'll be soliciting proposals for what those are. We'll take that and review it, and then provide a prioritized list of recommendations to the Joint Budget Committee sometime around February, depending on when the JBC can calendar us for that. So I'm sorry for leaving that out. I think that concludes our presentation on that. And again, we'd be happy to take any questions that you have.
Great, thank you. Board? Ms. Riley?
Judy Riley from Larimer County Human Services. So my questions are easy. One is that, is it possible for you to provide us with an electronic copy
Absolutely.
of the handout? Looks like it's public information at this point.
It is public information.
And we can share it. And secondly, I just wanted to make sure that the board knew that you have an upcoming hearing with the Joint Budget Committee. And do you know when that is, the first hearing?
Mr. President. Ms. Riley, yes, I do. Our briefing. So the
It's
JBC,
the briefing.
yeah, the JBC hearings and briefings take 2 parts, and I'll explain that briefly here. The first thing they do is the JBC sits around and gets a briefing from their staff. That will happen for the main HCPF briefing. It will be on December 2nd at 9 a.m., I believe.
Oh, let me get out myself.
I think I'm pretty sure that's at 9 a.m. and that'll be where JBC staff present about the department to the committee. The committee will then ask us questions, and we'll respond to those questions at our hearing, which will be December 9th at 1:30. Now, that is not the only time we're going to be in front of the Joint Budget Committee. We actually have a larger briefing and hearing schedule. In particular, there will be a separate briefing on issues for individuals with intellectual and developmental disabilities, and then also for behavioral health and related services there. I do not have those dates off the top of my head, but we will provide that information to Ms. Carey and get an email out to the board. And that information for those folks who are listening at home is also on the Joint Budget Committee's website. And while I don't have the specific URL for that memorized, I think you can do a quick Google search for JBC Colorado, and it'll bring up their website. And there's a link there to their calendar, which will have all that information.
I wanted to make sure the board was aware also that those committee meetings and briefings are open, and so you can attend them. You can get the agenda on the Colorado General Assembly website under Joint Budget Committee, and you can listen in to the hearings and hear the Joint Budget Committee grill the staff. They're very interesting meetings, so if you have a particular interest, particularly in some of these subgroups, you might want to dial in, even if you can't attend,
Great.
just to hear what kind of questions are being asked, and when the department does their response, hear what kind of response they're getting from the Joint Budget Committee. It's a very interesting public process.
Very good. Thank you. Other questions from the board? Ms. Roberts?
Donna Roberts, I was wondering if you have any sense of what the outcome will be, the openness of the legislators to your proposal?
The budget requests? Or that, which, I'm sorry, which?
Well, in general, particularly the ACA.
So, as you are aware, we had an interesting election last week. Kept us up all night. The Senate's decided, so it will be 18-17 with the Republicans in the majority, and then the House, there's one race still outstanding, but it looks like it may be 34-31 with the Democrats in charge, and they're actually doing leadership elections this morning, so I appreciate your flexibility in allowing us to head over there after this. You know, that means that the Joint Budget Committee split 3 Democrats and 3 Republicans, and so far I've met with members of both parties, and they're very open. They've asked really good questions. I'm hoping that we'll have just as a successful year as this year as we did last year. Some things will be a little bit harder, and that said, if you represent organizations that are supportive of our budget actions, please let me know. I'm happy to add your name to our list of supporters. The more supporters we have going to the Joint Budget Committee saying this is important to us, this is important to our clients, the better.
Thank you.
Mr. President, Ms.
Yes.
Roberts, I'd like to tack on to that. Even though for the last 2 years we've had single-party control of both branches of government here, the department has a very strong history of bipartisan cooperation in terms of our budget agenda and our ability to, or our collective ability to get these items passed regardless of which party is in charge. I think that's something that we are very proud of. When we look through our agenda, I'm hoping that a lot of these items are not controversial. I think the biggest obstacle that we're going to face will be funding. I think we're all aware that Tabor is a concern in Colorado and that it limits the amount of revenue that the state can take in, and thus the legislature always has difficult choices to make. You know, when we look at some of our higher cost items, such as eliminating the waiting list of children with autism, I don't think that anybody in Colorado would disagree that this is a need, that there are clients that are, or children, that are income eligible for services, that have a condition that requires help, and it's just a question of whether or not we're at a stage in Colorado where we can fund it. The governor's budget is balanced, and so there is money in the budget for this type of activity, and there's also, there's money in the budget for all of these activities, and so we're hopeful that the majority of these things can be approved, that they're not going to be partisan issues, but it's hard to say, and as Zach said, any support that we could get would be sincerely appreciated.
Ms. Gibbons?
So I'm sure you've already done this work in preparation for your presentation, but the example you gave, there are downstream consequences to not funding some of these things, and all of us around the table and in the audience are aware of those things. So documentation, like you mentioned, children with autism, if they aren't provided care, they end up in acute care settings, and the cost, we end up paying for it anyway. So I'm assuming that that's data that you already have.
Mr. President, Ms. Gibbons, that's correct, and I think we'll be talking about that as we get into our briefings and hearings. And on that particular theme, you know, I mentioned at the onset of this, we're requesting $714 million total funds. And even though, as I said, only $175 million of that is general fund, we are acutely aware that in Colorado's revenue situation, we have to be doing everything we can to mitigate long-term cost trends, and that includes serving clients, you know, in the right place, in the right setting, at the right time. I didn't quite get that phrase right, but I think the point's there. And so, you know, we're really working around reducing long-term cost trends, and that's what, you know, with the autism waiver, eliminating the wait list, that's exactly the goal there, is preventing that type of cost shift. Same thing with our Accountable Care Collaborative is, potentially paying a little bit more upfront for primary care services in the hope of reducing long-term costs. And by doing this, there are a lot of other economic outcomes as well that we're trying to achieve. Things that don't really show up in the budget process, but last year we began to implement an adult dental benefit, right? And that sort of stuff is really important in terms of better health outcomes. But by keeping people's teeth in better shape, they're more likely to stay employed and contribute to the tax base, and it has many downstream consequences. And so, really that long-term sort of cost growth is something that's incredibly important to us, and in particular, make sure that we keep a limit on those trends. Especially given the fact that we are acutely aware that the state does not have unlimited revenue to provide to the Medicaid program.
Absolutely, but I guess my point is that there are many stakeholders in the community that can help tell the story, and with the legislative people that are new to the process may not understand the downstream impact and the cost avoidance that can happen by investing at the front end in health. So for many of these things that you have on your priority list, so I just want to say, many of the stakeholder groups, I'm sure, would be more than happy to help provide that information.
And the more the merrier. I know that you all represent regions across the state, so it means more coming from a legislator from your district to hear from you than it does from me, even though I'm super charming. And you're their constituents, so.
Perfect. Ms. Birch?
So first I want to thank these two particular staff members. Both Zach and Josh have just really done an amazing job, and Zach works closely with Tom Massey, and all of you know Tom, and certainly Josh works very closely with John Bartholomew. So thank you to both of you, because this has been an enormous undertaking to narrow the requests, make things understandable, and package them up, and now beginning this process of really helping our legislative partners understand our challenges. So thank you, both of you. You really have done an exemplary job this year, again. And Zach, welcome to your new position, and we'll remind you that you're not as charming as you think.
That's true.
We have to help.
You've started off really good, though. So.
We have to keep raising him. But I do want to say, I want to follow through just on one more comment about this autism issue, because I think this really displays the predicament that our country and our state is in. So in Colorado, for example, for those of you that don't know, we have a more robust autism benefit on the commercial side. Medicaid has done, really incredible work with what resources we had, providing some autism services. Does that mean? But I think we now can no longer just function in our public kind of swim lane. We have to start understanding what's going on the private side. We have to work with our legislators to help them understand the differences. And then, oh, by the way, we have kind of federal directives with their autism guidance letters saying, hey, states, you're now we're giving you the go-ahead to figure out an autism benefit. So all of these things have to come into kind of a modernization, if you will, or update, refresh. And they really, they're complex. They involve many, many stakeholders, and absolutely consider yourself invited to the many different groups that are already in play, or if you think we're missing on a stakeholder group, you need to know about that, and that's part of your role on MSB. But I did want to just bring that out because it's a really good example of how in this new environment of ACA, and I think, Donna, your question too about kind of the implications of ACA, I think they might have been directed to at the federal level with the federal Senate change. And, again, everything is in play. Every week every day we have new information, and we are really trying to continue to harness kind of all the impacts of things going on, making certain that we have a committee or a process and that we're on top of the content. And it's no small task, but this team's up for it, and we continue to play that out. And as you have new information, too, about science or content, or, again, on the process, if things aren't right, you are our eyes and ears out there as well. And it really helps for you to come back and give us that information. But we will get to a better autism place in the state by really morphing the public and private information and the science, and really kind of continuing in this process as we go forward. So Thank you, gentlemen, for spearheading all that.
Any other questions or comments from the board? I would just like to add that I really appreciate the synopsis here of these topics. I think it's very easy to read, and we look forward to kind of being updated about that throughout the year. So appreciate all of that. Go back to the legislation then and see what you can do. So thank you all very much.
Thank you very much, sir.
Okay, now we're going to jump into the rules portion. We've got 6 rules on the consent agenda. If any board member would like to pull a rule from consent, we can. Otherwise, I believe Brenda's been warming up here to do this motion.
Yeah, Mike says I've been really quiet these last few months, so here goes. Move the final permanent adoption by consent of document 01, MSB 14-07-28-B, revision to the health program benefits and operation hospital services rule concerning, how do I say this word? Bariatric surgery, section 8.300.C, document 02, MSB 14-07-28-C, revision to the medical assistant health programs benefit and operations rule concerning dialysis treatment centers, section 8.310, document 03, MSB 14-05-06-A, revision to the medical assistants managed care contracts division rule concerning billing procedures, section 8.564, document 04, MSB 14-07-28-D, revision to the medical assistant client and clinical care durable medical equipment rule concerning complex rehabilitation technology, section 8.590, document 05, MSB 14-09-03-A, revision to the medical assistance eligibility rule concerning 5% income disregard, section 8.100.4.D, and document 06, MSB 14-06-19-A, revision to the medical assistance eligibility rule concerning long-term care institution recipient income calculation of patient payment, increase to the personal needs allowance for residents of nursing facilities or intermediate care facilities for individuals with intellectual disabilities, section 8.100.7.V, .3, .D, and F, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Nice job.
Second.
And we got a second. So we got a motion and a second on the consent agenda. All those in favor signify by saying aye. Aye. Mr. Fox?
Aye.
Very good. We've got approval of the consent agenda. Before we jump into our permanent adoption agenda, Ms. Riley asked a question last month, and we have Eric Stricka here to provide some background and answers to those questions. So, Mr. Stricka, come forward.
Good morning, Mr. President and members of the board. I'm Eric Stricka. I'm the long-term sports and services eligibility policy person for the state. And the question that Jeannie asked last month was kind of quite simply, why do we have an asset test for certain groups and not other groups? And it could go into a day-long conversation about that, but the basic reason why is Medicaid kind of follows two different umbrellas where we're required to follow the rules that are set in the closest related cash assistance programs. So those programs are the AFTC and also SSI. So the AFTC ones, all those categories have had the asset test taken away years ago. and there's been a lot of things happening with those categories, especially with the Affordable Care Act and everything, with the expansion programs. The SSI-related categories and the options under those, there hasn't been a whole lot done in really in a very long time with those. So that's why I'm working with Josh and Julie to see what kind of options we can do to kind of help out with certain situations under those programs. But that 300% special income category, which most people just call long-term care category, is under that. So that's simply the kind of the reason why we're required to follow those. And we do have some options that we're going to explore.
Ms. Riley?
And just for the board's understanding, I asked the question because we had a testimony from someone who really touched my caring place about not being able to save for college for her kids and that kind of thing. And my interest was, is there anything that we can do about that? And it sounds like you are exploring what our options might be, and I appreciate that.
Okay, thank you.
Very good. Any other questions for Mr. Stricka? Otherwise, thank you. Appreciate the follow-up on that. Thank you very much. Moving into the final permanent adoption agenda, if I could have a motion for document 7, please.
I move the final permanent adoption of document 7, MSB 14-06-04-A, revision to the medical assistance home and community-based services home modification rule for persons with brain injury waiver, community health supports waiver, spinal cord injury waiver, and elderly, blind, and disabled waiver, section 8.493.3, incorporating the statement of basis and purpose and specific statutory authority contained in the records. Second.
Got a motion and a second for document 7, and we have Colin Laughlin here to present to us. Welcome.
Thank you. Good morning, Mr. President, members of the board. As Mr. President said, my name is Colin Laughlin. I manage several of the programs within adult home community-based waivers for the department. One of those programs is the home modification benefit, which, as Ms. Givens mentioned, serves individuals on the elderly, blind, disabled waiver, the brain injury waiver, community mental health supports waiver, and the spinal cord injury waiver. I presented last time, and I know there was a couple questions, so I'm here to present some additional information and then also provide some clarification. So first and foremost, I think the biggest issue and one of the concerns that was brought up was that there was mention of $20,000 within the appropriation, the legislative appropriation, and as I had paraphrased, that appropriation had specified that the money that was made available to the department, which was about $500,000 general funds and then $500,000 in some change of the federal match, was to be used to raise the cap within a feasible amount to up to $20,000. And so I wanted to take a moment to read the actual kind of wording from the long bill. It states, the Department of Healthcare Policy and Financing, medical service premiums. This appropriation includes $1,015,383 in total funds, including $500,000 general fund and $515,383 federal funds for the purpose of increasing the current $10,000 lifetime cap on home modifications by an amount projected to be feasible within this level of funding up to a maximum lifetime cap of $20,000. The lifetime cap issue, obviously being at 10, we know and we've spoke with many providers, many people over the years, understanding this really has not gone anywhere. It has not adjusted for inflation, it has not adjusted for cost of living, and especially relevant here in the last several years, it has not adjusted to the cost of home ownership and rental prices here within the metro region, and Colorado kind of in general. And so it's certainly something we understand. That appropriation that we were given, the budget department did projections, and that appropriation turned out to give us the ability to put an additional $2,500 into the lifetime benefit. There were questions on what is the amount to get to $20,000. We had spoken with our budget analysts. Josh included, kind of helped with this. That overall amount would be an additional about $3.2 million that would need to be appropriated to get to a $20,000 lifetime cap. Now, understanding there's a lot of work that needs to be done on this benefit, not just money. And I think Ms. Blakely, yourself, and Josh were certainly very clear in some of the concerns, and those were taken to heart. One of the things we know kind of from the beginning is that we as a department are not subject matter experts in contracting. We don't understand really kind of how these things work, what the costs associated with these projects are. And so to that end, and we spoke about this a little bit last time, is that we are currently finalizing, and Executive Director Birch actually signed it last week, the interagency agreement to move oversight and quality control of this benefit to the Division of Local Affairs, Department of Housing. And so we anticipate that work to be done here shortly. Once that work in that IA is finalized, it's to the last signature right now. Once that work is finalized, we anticipate in pretty quick order finalizing a work plan that will ultimately lead to oversight provided by people who actually know what contracting work should look like, ensuring appropriate permit polling, ensuring that costs associated with bids are actually within the realm of what the cost should be, trying to avoid what Josh mentioned as a problem that someone has an OT evaluation done and all of a sudden their benefits maxed out because on there the contractor may just write $10,000. We do know that we have some great contractors in this business, and certainly we're planning on relying on their expertise to really streamline the benefit. To that end, what this particular rule change is not a redesign or reevaluation of the benefit. This is an increase in the money that is made available to individuals for a lifetime CAB. Additionally, it provides clarification for case managers that allows for repairs to be done for previous home modifications, as that has been an issue kind of throughout the lifetime of this benefit, where someone may have a ramp already, and as you can probably tell from outside, our weather can be somewhat harsh, and wood sometimes tends to rot, frankly, if not taken care of appropriately. And so what we're seeing is modifications that have previously been done not being able to be upkept, issues with people being able to get out of the house. And we know that this benefit, especially for individuals who are returning to their home for the first time, this is to me a cornerstone of home and community-based services. I mean, this is kind of the whole home and community-based portion of this. Combined with all the services that we also offer in our waivers, we believe that this is a very meaningful benefit to a lot of people, but we do know that there are issues with it. And so what again we're trying to do is not right now redesign it. We're trying to get the money available to people. That said, the goal is, and we've recently brought someone on board to help with this project, help me with this project, but the goal is to actually reopen the rule this winter and work with our case managers, our providers, our clients, other interested parties to make sure that this benefit is effective and is providing that meaningful service that keeps people in their homes, that allows people to return to their homes. And so our commitment to moving this process forward, now that I'm managing this benefit, I can speak for both myself and the department saying that this is a very high priority for us to get done. We know that there are some very minor things that we can do to fix the issues associated with this. I was actually speaking with a provider, and he made to me what was a very profound comment, and it just seems so simple, is that the OT eval forms, they're all different. It could look as simple as kind of the back of a napkin, this person needs a ramp, to a very official type documentation with all of pages upon pages of rationale as to why someone needs this. And that in itself creates issues for case managers who, again, don't have background in approving contracting work, don't have background in understanding what's appropriate for individuals. And so standardizing forms, putting something in the form that allows for people to essentially list the from most important to remaining independent in the home to maybe the less important issue or modifications that can be made in the home. And so those are simple changes we can make off the bat. We'll work with our OTs, we'll work with our other folks in the community, we'll certainly work with our providers to see what works best for them. But those are changes we can do just from a systems perspective that we believe can definitely clear up some of the issues associated with some of the things that Ms. Blakely and Josh had spoke about last time. And so finally, I'm more than happy to go a little bit further into what that process with the Department of Housing will look like. But I did just want to reiterate, this in itself is a first step. We know it's not a first step that's addressing most of the issues. It's probably only addressing one minor issue right now. But we believe that issue is big enough to clarify in this one. We also want to make sure that money is available to people as quickly as possible. We know that there are people who are at their lifetime limit who right now can't get repairs. This benefit would solve that. Is $2,500, to Josh's point, going to be kind of the make or break for a lot of people? Maybe not. I would argue that it would in some cases. But I do believe it's a step forward, and I do believe that as we move forward and certainly work with our provider partners, revitalizing the benefit, redesigning the benefit so it's more effective, that we will ultimately be able to make steps forward, and then as a department look at expanding that benefit even further, potentially increasing the cap. And I think there's some other interesting things that we can do, taking ideas from other states and how they implement this model. Overall, we are excited about the prospect of doing this work, and I'm more than happy to share a little bit about what we're doing with DOLA, like I said, but I just wanted to come and kind of reiterate a few of those things and then make some clarifying statements as to what the appropriation looked like.
Great, thank you, Colin. Questions from the board? Ms. Riley?
I am wondering if this rule passes first reading, and it's not an emergency rule, so we have another month. You're going to be
this is final permanent.
This is final.
It passed last month in first reading.
So even in that case, you're 7 months away from the end of the fiscal year. And do you have any concerns about being able to spend that appropriation with only that much of the year left?
Right. So that's a great question. This was spoken to a little bit last time because it is somewhat complex in terms of how everything has to move together. And so our federal partners put out a new rule as to what a home and community-based setting looked like in order to amend our waivers to account for the additional rate or the lifetime cap for the home modification benefit. We had to first come up with a transition plan to specify how we were going to meet, for every setting within every waiver, how we were going to meet the new federal criteria. And so that did put a bit of a hamper on our efforts to push this forward more quickly. That said, and per my conversation with budget and some of the things I've already spoken to, is our projections are based on and have been updated throughout. What we see just in terms of the money being made available still puts us at 12.5. I think that, again, if you look at the program, on one hand, it's great that it's being utilized. Projections for utilization continue to increase. Projections in actual utilization, real utilization has increased over the past several years. But we know that there are issues associated with it from being a truly very effective program. And so the changes that we're making to increase this cap, from what I understand from our budget department, have taken into account kind of the time lag that's associated with this. And as we move forward with our budget and what I know some outside stakeholder groups are looking at, we will obviously look at that again if that's something that would happen. But this is, I think, where the budget department has felt comfortable with pushing forward.
Okay.
My second question is, just out of curiosity, are the services provided to the client in their home sales tax exempt to save them some money?
In terms of the contractor? Well, so that's a great question. I would need to do a little bit more research to see if they're exempt.
You have an individual behind you nodding yes, so.
They are exempt because it's a bid. So my home mod guys are back in the post. Yes, it's exempt.
That's a good way to save money.
All right, there we go.
So thank you for answering.
Thanks. Dr. Young?
I just have a comment. It sounds like there's going to be more oversight of the quality and cost of those repairs and maintenance. My husband, being in this field, has multiple stories of just being actually pretty appalled by the cost that some of his fellow contractors charge for some of these modifications, and then being called in to fix some of that stuff. So I think it is a big area of concern and something that does need to be monitored. I mean, I'm just talking for personal experience and some of what his work is in putting in and fixing things.
Right.
So I think that's important.
Thank you, and that's a great point. And to that end, we do have great providers, and certainly no one's making a ton of money off of this program in kind of that realm. I do know that one of the things, and this I think kind of gets to some of what we're trying to do with the Department of Housing. We have known for a while that when a contractor goes out and puts up the bid, oftentimes the person who's having that work done doesn't fully understand what that will look like. They hear ramp and they have one thing in their mind, and you know, that's kind of that, and then they send an email to someone saying, you know, this was done, I thought it was going to look different. We don't have a great way of ensuring that both parties, both the contractor and the client, understand what that is going to ultimately look like and what that work is going to allow them to do. And so one of the pieces that we intend on doing with our partners over at the Department of Housing is work with them to have a process that on the front end, once the bidding is done and that bid has been awarded, to the contractor and the client have an agreement as to what the scope of work will look like. The client actually more or less signing off on that, saying, okay, I understand what this will look like, and this will meet my needs. The contractor saying, okay, this is what this will look like, and we have this agreement. And if there's any deviation from that, we can then take action. Because right now it is, to your point, it is somewhat difficult to say after the fact, well, this wasn't done exactly like how I thought it would be done, or this was done poorly. When we know some of that's happening, we just don't have a great mechanism to fix it. And so we believe that that's a great way to ensure that the client truly understands, is satisfied with the work, and then at the end of that process, actually having, before the final payment is made to the contractor, having the client sign off on that, saying this has met my expectations, this is within the scope of work. And so having that quality control where it's hopefully avoiding situations, not to take work away from your husband, but avoiding situations where he's having to go back out there and redo work because it was either not within the scope or was done poorly.
Great. Other questions? I appreciate the importance of this rule and the importance of that cap, and I also really appreciate your being able to tease apart the feasibility number versus the maximum number. And this being the first step, I think we're in a good place. You talked about opening up the rule. Do you have a time frame on when we could potentially be looking at this?
Yep, and I was going to actually catch Ms. Blakely before saying to expect an email in the next couple of weeks. We hope to start this process in sometime in early January. We know that trying to kick off what I imagine will be a pretty big undertaking between now and the holiday season might be a little ambitious, and people might not be around to start and be involved as much as they could. So we're looking at early January.
Great, thank you. Other questions from the board? Otherwise, we have a motion and a second. We don't have anybody signed up for public testimony on document 7. Would anybody like to sign up for document 7? Seeing none, I'll call the question. All those in favor of final approval adoption of document 7, please signify by saying aye. Aye. Any opposed? Mr. Fox?
Aye.
All right, document 7 passes, final permanent. Thank you. Moving on to document 8, if I could have a motion.
Move the final permanent adoption of document 08 MSD 07-15-A, revision to the medical assistance community living benefits rural consumer directive, attendant support services 10 CCR 2505-10 section 8.510, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second.
I got a motion and second for document 8, and we have Candy Dalton and Kelly Jepson here. Welcome.
Good morning, Mr. President, members of the board. Can everyone hear me okay? I had
Maybe pull a little closer and speak a little louder.
better.
I can turn it down a little bit.
That's okay. Just let me know if, as I'm presenting, if everyone can't hear me okay. My name is Kelly Jepson. I am a contract benefit specialist for the department. This is second reading. As you all know, we brought this rule to first reading last month. We made a few minor changes to the rule per the AG's instructions. So I'll give another brief overview of the rule and the changes and the reasons for them, and then I'll go into those details and then ask any questions if you like. So this rule is in regards to Section 8.510, Consumer-Directed Attendance Support Services. As you all, I'm sure, are aware, we are going through a major FMS transition. So the FMS is our Financial Management Services component of CDOS. It's basically the payroll administrative service for CDOS clients in order to pay their attendance. So the purpose of this proposed rule change is basically to allow the department to offer additional FMS agencies. Currently, we operate in the state of Colorado with one FMS. You all know them probably as PPL, Public Partnerships. This rule change will enable the department to offer additional FMS agencies in addition to a training and operations vendor who will take on statewide training services for CDOS clients and their authorized representatives, as well as case management statewide. So we're really excited about this change. We've gotten a lot of positive stakeholder feedback, and sort of the purpose of this change is also to offer CDOS clients additional choice. So this rule change will also enable CDOS clients to offer to choose from one of two employer models. There's the agency with choice model, in which the client and the FMS are co-employers and serve a co-employment function for attendance. And then there's the fiscal employer agent model, in which the client is the sole employer for CDOS attendance. So again, we're really excited about this change. It offers them the ability to choose how they want to direct their attendance and in providing the care. So that's really the reason for the rule change. We're on second reading today as opposed to consent. We had a couple of minor adjustments to make to the rule from last month. Two of which being just minor citation changes and corrections. And then one of the other ones, I believe, was at the direction of President Stahl. You'll find on line 5 of the rule, we basically just spelled out financial management services, the first place it's mentioned in the rule, so everyone's clear. And let me see, I think that was everything. Let me know if you have any questions. I have Candy here, Candy Dalton, in case I missed anything.
There were no substantial changes to the rule from last month to this month.
That is correct.
Great. Ms. Blakely?
So question, who got the contract for the training, and where would I find that citing or that? It was my understanding that they're already putting out for employment, et cetera, but for Colorado folks to do the training, but I haven't seen or heard anything of that.
That is correct. So we only very recently awarded the contract to the training and operations vendor that will be Consumer Direct, based out of Montana. They did. Are you asking if? I'm sorry. What are you?
So Consumer Directed is the company.
Consumer Direct, yes.
Is the name of the company, and where are they posting employment?
That's a great question. I'm not positive where they're posting their employment ads at this time. We sort of the contracting process has gone really quickly, as I'm sure you're aware, because we're sort of bringing all these contractors on
I'm really having a tough time hearing you.
Oh, okay. Is this better?
Voice with me, please.
Okay. So we are sort of completing that contracting process, both for the training and operations vendor and the FMS agencies, very quickly. I'm not certain where they are posting. I know that they're looking for their staff that they need to hire per the contract. I think they are seeking Colorado located individuals, but I'm not sure exactly to that process. I think some of that is left up because they are a business. And so I'm not sure, I can definitely get back to you and ask them how they are completing their employment outreach. We only recently awarded the contract a couple of weeks ago, and we're working, we haven't actually executed that contract yet, and so at that time we'll work very quickly on bringing them up to speed with consumer direction, and so they can actually begin providing those training services for their operational start date, which is not until January 1st. Does that?
Thanks. Other questions from the board on document 8? Do we have anybody signed up for public testimony? No? Would anyone like to sign up for document 8, public testimony? Seeing none, we do have a motion and a second for final permanent adoption of document 8. All those in favor signify by saying aye.
Aye.
All opposed? Mr. Fox?
Aye.
Aye. All right, document 8 passes. Thank you both very much.
Thank you.
Appreciate that. We're going to take a, well, let's do the closing.
What do we do about the table rule? Table rule.
Oh. If I could have the closing motion.
I move that all rules adopted at this meeting of the Medical Services Board of the Colorado Department of Healthcare Policy and Financing meet the criteria of the State Administrative Procedure Act, which are incorporated by reference.
Second.
Got a motion and a second. All those in favor signify by saying aye. Aye. Mr. Fox?
Aye.
Aye. All right. Thank you very much. We're going to take a quick break and round up Suzanne Brennan and do a quick thank you from the board. So how long do we need? We want to come back at 10:15?
Yep.
10:15.
Oh, I'm sure. You know, I think that Department of Local Affairs.
I agree. I agree. How are you? Good. How are you? Needed to steal minutes of your time. Okay, cool. Yeah, I said a few things last time.
Do you want to,
No pastries for me, thank you. It's part of my new thing I'm trying to be healthy.
Thanksgiving and Christmas. My sister sent me this challenge and said, let's not have any sweets before the whole month of November. I said, we got the cake. Get the things.
Yeah, exactly. And that's when every one of your clients starts bringing things in to you.
Yeah, and I was like, no, I'm not doing that. I'm not. Just forget it.
Did you do your closing? I did, and then I splashed it, so I think I should redo it.
Oh.
I'm sure you did. Yeah, I'll be back
Afraid I'm going to log myself out again.
I did too. Mine keeps popping out.
Another beautiful sweater.
I just backed out the wrong way again.
When is it? Yeah, when is it?
It's up in Longmont.
Okay.
The first weekend in December. It starts like Friday, Saturday, Sunday. Friday, Saturday, anyway.
Okay.
So just Google Icelandic and it's a warehouse sale.
Okay, cool.
$27.
Really? Okay. Maybe I'll see you there. Yeah, I know. I'm
Is there
looking
not?
to do it. I have all kinds of ideas. At least for a little while. Until I do my next thing, whatever that is.
Thank you.
Just wear it.
Oh, thank you. I think so. Okay, we're going to call the meeting back to order.
No, because I got some people waiting in my office.
Mr. Fox, are you still on the phone?
I am.
Okay, great. Thank you very much. We want to take a quick break to find Suzanne Brennan somewhere in the building, which we were able to do, so that was good. And wanted to just spend a couple minutes thanking you for your service. We know this is your last Medical Services Board, and that you're moving on to a different chapter in your life from the state of Colorado. But we put together a certificate of appreciation presented to Suzanne Brennan by the members of the Medical Services Board, and we wanted to make sure you had something to remember medical services by.
I'll never forget it, never. Especially certain meetings, more than others.
But we really do appreciate everything you've done, not only for medical services, but for the state of Colorado, and your service to the state is very, very much appreciated. So thank you very much, and I know Director Birch would like to say a couple words as well.
So I just want to take this time as well to thank Suzanne. You know, most Medicaid directors in our country don't even last 24 months. And Suzanne's been amazing with the lift that she has created. You know, when I started this work, I talked to you early on about, you know, we've got to come to a series of culture changes. We've got to get people to understand, we've got to move out of sick into wellness, and we've got to use technology, and we've got to shift up our workforce, and we've got to change our service delivery, and we've got to change how we pay for things. And Suzanne has embraced all of those culture shifts in the work that we are really, we either have framed up or in motion, or nothing's completed. But really, when you think about Suzanne's efforts here, the person-centeredness in this department has shifted dramatically. When you think about clients and consumers getting their needs attended to, and phone calls being returned, and really the department has become so much more consumer oriented and friendly because of Suzanne. The work around really fully loading the Accountable Care Collaborative. I mean, I remember penning the first contracts. And so Suzanne's just done an amazing job. And then the last piece that really she's just been steadfast about is this tri-agency work, the work with our sister agencies. And really, I do believe that the legacy, certainly of this administration, and certainly Suzanne has helped deliver on, is that we work together across the silos and across our silos of excellence. But no, seriously, the work, these cross-matrix teams and whatnot. So, Suzanne, I just wanted to thank you, and I know the board has really appreciated your work. But this is our first of a series of thank yous for Suzanne for taking on this very heavy lift of transformation.
Thank you very, very much.
Well, thank you all, and like I said last month, it has been a pleasure to serve on the board. Great educational opportunity for me, and opportunity to partner with you and the community. So it has been the opportunity of a lifetime, the experience of a lifetime to be part of history with ACA, and so it's definitely bittersweet. You know, there's positives and negatives, and I am sad to leave, but it's definitely time for, you know, new things to happen. So, but I do want to thank you all. It's really been a pleasure. You've been great to work with. So, thank you.
Thank you. Thank you very, very much. Appreciate that.
You're very welcome. And I am very happy.
You're welcome to, hang out for the rest of the meeting now if you want, just for old time's sakes.
I do. I have people waiting in my office who I'm trying to make sure have a good transition. I did want to say I am really glad we made progress on traumatic brain injury. I mean, that's one thing. I have a compulsion to want to make things better, and to have that languish for years like that was just unacceptable. So I am glad we could do things like that and a lot of other things as well. So, yeah.
Great.
Thanks.
Thank you very much. Appreciate everything.
All right, I'm going to go back to my meetings. All right, thank you all.
Okay, next on the agenda is open forum for public comments. I had looked just previously, nobody had signed up. Is that still the case? And would anybody here like to sign up for public comments? Okay. Seeing that nobody has signed up, we'll move on to department updates. In our packets, we received House Bill 1293, a written update to that, so I'm hoping everyone's had a chance to review through that. And if there's questions, I'm not sure if anyone's here to answer those questions, but we have it in our packet to be able to read through that. We've already heard from our legislative and budget update, and so then the next is the department and state shield presentation. We have, you don't look like Colleen. You must be Brendan?
I am.
Brendan Donlin here to present to us. And this is also on our iPads, and the presentation should be on our iPads, right? And you also, okay, you got the handout here that just came, so welcome.
Thank you.
Bottom right corner is 35%. Top line.
So,
Mr. President, members of the board, my name is Brendan Donlin, and I'm the new Employee Engagement Specialist here at HICPUF. If you want to follow along, we have the slideshow on the screens as well as in the packet in front of you. I'm the new point guy on the new department look and feel. To kind of explain who I am, I'm the new Employee Engagement Specialist. A lot of what the new department shield about, of course, is client engagement. My role here is employee engagement. I'm here to help with internal communication. There's been some employee surveys that says communication around HICPUF leads to more intrinsic motivation. I've been brought in to try and enhance that employee engagement.
Is there chocolate involved? I'm just.
That might actually help.
It never hurts.
Never hurts. So to quickly go over what I'm going to tell you, we're going to go over the overview of the changes regarding the shield. Explain a little bit about the outdated shield, the new templates. We'll get the accessibility standards that are embedded in those templates. Then we'll also touch on the new Medicaid look and feel as well as the new PEAK look and feel. So you will see the old department shield, the old seal. This is on all the department phones, podiums, and a lot of meeting rooms. And this will be replaced by the new shield you see underneath that, the icon with the children on it, about the fourth slide there. And so to tell you a little bit about how we got here. So the governor started Brand Colorado, and in each one of these slides, in the bottom left corner, you'll see that new Colorado branded shield. And he came up with that to try and describe Colorado's ascension and to come up with a Colorado-owned, if you will, logo. The Colorado state flag and other seals were public images, so they couldn't control that. So they came up with their own shield, and then they wanted each department to come up with a shield that also kind of partnered with that. And thus, we have our shield with the people on it. Initially, we had one design, but that came back because we wanted to partner it with Medicaid. But we found out the logo we initially really loved was trademarked. So we went back to the table before we went live, but it gave us a chance to really assess what we wanted to be represented in our logo. And so after looking with our sister agencies, we really decided we wanted people in our logo. We serve people, let's have that in our logo. So this just went live November 1st. So what that means is each department, along with ourselves, is moving by December 2014. So on that page, you will see there are other department shields that also have people. CDHS has people. You'll see there with the yellow background. CDHPE has the hands that make the leaf. So thus, we are in alignment with our sister agencies. It's a requirement for our upgraded website to have this new shield. And the timing, because that's a big question, is what do we do with all the business cards, our marketing material, et cetera. So we're going to exhaust what we currently have, and then once those are exhausted, go ahead and launch everything new you need with the new logo. What you'll see from your end is you'll see a new department signature blocks. You'll see new slideshows, much like the one in front of you. You'll see new fact sheets, new letterheads, new listening logs. Everything will be rebranded with our new shield that you're typically used to seeing in document form, material form, all those things that end up in your email inbox. Those templates are now being worked in with ADA standards, and that's accessibility standards. What that means with the accessibility standards is meeting the needs of our clients. What we found is a lot of clients use assistive technology to be able to read documents. Maybe they need the font changed, maybe something reads the document to them, maybe it needs to be increased in font size by an extreme amount. All that assistive technology helps them read. What we did with our templates was we embedded all these accessibility standards into them. So as you craft the template, as you craft the letterhead, so on and so forth, if you were to post that document publicly, anyone who uses assistive technology could be able to read that document, thus trying to engage our clients, making everything that we post, everything that we gave out, readable by everyone. But that is not the only logo refresh we're going through. We are next year going to also redo our Medicaid logo. The exciting thing about that is transformation is happening, as you guys are well aware of. There's new benefits in dental, there's expansion, new population, and overall there's been quite the effort on client engagement. So again, in the coming year of 2015, we're going to have a new Medicaid logo. It's going to have a new tagline. It's going to try and represent the diversity of our clients.
that is not the only logo that also just got redone. So not only the HICPUF shield, not only is Medicaid coming, but currently the Peak logo was also redone. So you'll see there a picture of the past Peak logo, kind of the maroon and black peaks there, and then you'll see on the next slide the new Peak. And what's really neat about this Peak is that it combines the colors from all the different department agencies, and we melted it into one with the brand Colorado Green. The neat thing with this is that it has the web address in the picture, again, trying to make clients more engaged, trying to reach out on all the different communication vehicles that are available to our clients. Again, all trying to aim at our new look and feel and enhance that engagement piece. So 3 total redesigns kind of happening in this winter window. Medicaid's the big one coming out next year, and that'll have updates as well. Any questions?
Questions for Mr. Donlin?
Thank you for your time.
Mr. President,
Judy?
if I could mention that actually they also have developed a medical services board logo. So when you look at your agenda and the certificate for Suzanne, you now have your own logo.
Did we ever have one before?
No.
Cool.
It's official.
We've got a logo.
Yes.
So I do want to just add that, you know, Colorado has really embraced kind of this good government, and this re-imaging and rebranding is really, in my opinion, really important. And when you look at what is happening with healthcare reform across this country and the confusion that's occurring because of the exchanges and whatnot, I hear all the time from the commercial private carriers, oh gosh, we are starting to get more features of kind of public products, and public products are starting to get more features of commercial products. And in fact, in Colorado, we have not lost the name Medicaid, and we need to lose the name Medicaid because there are old stigmas attached with it. And as we all know, the Silver Benchmark Plan, which is now the new co-op plan, which confuses people as well, because it used to be based off the Kaiser plan. It suggests to us that we probably need to modernize, and you'll be hearing more about our losing the Medicaid name. We are we are late to this game. Many states have already lost the Medicaid. They don't refer to it as Medicaid anymore. In Oregon, you know, they've got their product, Sooner Care, Badger Care. You've got all sorts of other names for Medicaid. And it is part of this normalization and this continuum of coverage that people are trying to get to. So we will be back at you with what's next. This base that our team, our communications team, has laid is critically important because we don't want the confusion. And you can imagine if you are going to churn, if you are on Medicaid now, but then you churn to a different kind of Rocky Mountain Health Plan product or a different Colorado Access product or a different Kaiser product, and you're going to churn back. And am I Medicaid or private or what am I? It's really important that we create that harmonization. So I just tell you that more is coming, because I want you to be pre-warned, more is coming. And we are being really thrifty as we go through this transformation and modernization with healthcare reform, because we have in fact said we're going to spend down the old supplies of things. We're not wasting money. We're very green here. But I really appreciate what Tom Massey and Brendan and the team have done to kind of go through this process along with other state departments. So appreciate everybody's understanding, and we want your feedback too as we go through this. But I really look at the incredible work that was done with Connect for Health, and now the Peak work and the single streamlined eligibility, and how they're trying to ease kind of the what system am I in? Am I in this public portal? Or am I in a private portal? And how do these things come together? And I really think the blending, the transformation where you're taking people kind of back, kind of from the private systems back into the public systems is really appreciated, because we're stressing people out.
We saw the website last month and saw how user-friendly that is looking, and I would say the logos are a simple thing, but they just add to that user-friendliness, and the appearance of it just all blends together. So really, very nice job.
Thank you.
Anything else from the board? Great. Thank you very much. Appreciate your time.
Thank you.
Next on the agenda, Government Relations and Partner Outreach presentation. We have Christina Martinez and Mike Wagner.
So I'm going to just, while they're walking up, take you into this as well. So again, because we're creating these culture shifts, we stress people out. We don't mean to, but we're trying to help ease change and help people with change aversion. And so we, a long time ago, really understood the need to really step up our team of folks that work with counties. And so here they are. These two have done an amazing job. And again, because we're shifting so much with workforce and partnerships, and so I want you all to hear from these two about the great work that's being done in partnership, not just kind of here at the state level, but down to the local level, but they also kind of move into the federal space, and then they move into the private side, and so they've got some very interesting maneuvers that they've done, and so I'll hand it over to you two.
Thank you. Welcome.
Good morning, Mr. President, Director Birch, and members of the board. Thank you for allowing us to come before you today. It's great to see some familiar faces around the table. So Mike and I, we are a team, and we work with the 64 counties across the state of Colorado, and then we also have our particular areas that we do independently as well. So Mike, if you want to...
Sure. Good morning, board. My name is Mike Wagner. I'm the county liaison here at the department. As Christina just mentioned, our job is really to build those relationships and look for opportunities to collaborate and coordinate with our county and local partners. So not only County Human Services Director Riley, familiar face for us here, good supporter of the department as well, but also some of the other partner agencies. And we've really started encouraging non-traditional partnerships over the last year or so. For example, we're really encouraging partnerships with sheriff's departments at the local level. And you may not think Human Services and Sheriff's Office probably have a regularly weekly meeting, and they don't. But we're really trying to encourage some of those partnerships because obviously the needs are sort of similar and crossover paths. So we want to highlight some of the great work that we've been able to do with the counties over the last 6 to 12 months, and really highlight the work that the counties themselves have been doing. As you know, this state is a county-run, state-supervised system. So the state sort of supervises at the higher level, but the counties are really the boots on the ground that do the work day to day and have the interaction with the clients. So we want to highlight through Medicaid expansion, increase in population, increase in workload, that their performance has really not dropped off over the last 12 months or last open enrollment period. If anything, it's remained steady or improved in quality and timeliness, in adjusting to all the new rules and new systems and new logos. They've really kept up with service and really been able to meet the demand, which has been great. And Director Riley, I know that you're the only director here, but we appreciate all the work that you guys have done, specifically in Laramie County as well. You're always one of the top performing counties in the state, so we appreciate that. Yeah, that should definitely be recognized. They've got a system that others have come and visited and modeled from across the state, and are looking to set the example, and they always have done so. So, due to increased federal funding over the last year or so, we've been able to put a few programs in place to sort of reward or incentivize those counties that have done such great work. County contracts, incentive contracts are out there right now that are basically made available to reward counties for performance. So those counties that have been performing well will be able to provide them with additional funding that will actually reduce the county share at the local level. So they'll be provided by the same level of service at a lower cost to the county itself. We've also developed a program in which, again, if you're collaborating with non-traditional partners such as the Sheriff's Office, maybe local public health, some of the RICO partners, some of the medical assistance sites that may be in your community, again, we'll provide you incentives for doing some of that work to really look at access to care and availability of care for beyond just the eligibility determination. So we've done a lot of work for the last 12 months in getting folks enrolled and eligible. We really want to start looking at that picture beyond eligibility. Where do we go and how do we get access to care beyond that? Another program that's been developed is a grant program that, again, through federal funding has been made available for counties to apply for grants that can support maybe one-time or short-term projects to meet needs that maybe local funding couldn't support. We've started receiving quite a few proposals for that here, and we'll be evaluating over this next few weeks to see how we distribute those awards. We've also worked with medical assistance sites. We really are looking again to try and partner traditional county human services office with other support systems to build contingencies for increased demand. So during open enrollment, obviously demand on services are stretched thin. We want to make sure that when that wave sort of comes in, we've got contingencies in place. So we're encouraging partnerships between medical assistance sites and the counties. The medical assistance sites can process medical applications through CVMS just like a county can. So that really helps reduce some of the impact and workload on the frontline county staff when their demand is high. So we've been able, again, through federal fundings for the first time in existence, provide funding to medical assistance sites. I think there are about 9 sites right now currently across the state that varying degrees provide support and services to support the county's work in getting folks enrolled in eligible Medicaid. Those are some of the big projects we've done over the last 6 to 12 months. Again, we want to thank really the county directors and the association, Human Services Directors Association, for their partnership and work with the department. I've been here almost 3 years now, and the relationships and the partnerships we've had at the county level have just gotten better and better. And I think it really shows the commitment from the leadership here at the department at the county level to really build that partnership and relationships to make sure we're working together towards the same goals. A lot of times you hear state government, local government don't necessarily always see eye to eye, but I think in this agency we're doing a really good job at working together in a common goal. So.
I think that we've also worked to strengthen our relationships with county membership organizations. As Mike mentioned, there's the Colorado Human Services Directors Association. We do our best to travel across the state to attend regional meetings. There are 6 regions across Colorado, and so it's not uncommon for us to be traveling to Glenwood Springs or Sterling or down to Canyon City, down to Southwest Colorado, because that's really one of our main tasks as well, is for us to not only communicate, but also to visit our communities across the state firsthand. And in that vein, we also work to schedule site visits for Executive Director Birch, other members of our executive team, because I think at the end of the day, it really reminds us why we do what we do. And to have that local connection of all the decisions that are made in rooms like this by folks like you that then are tasked to our staff to implement. But really it's the folks on the ground that are doing the work and the direct services with the client. So it really helps provide that holistic picture and gives them a perspective of, the drive is just as far to Fort Collins as it is to Denver. I have a rural background, so I can appreciate that and have lived that. I think that we've also done a very good job of cross-agency collaboration. I know you've heard some examples of some data measures that were just released today related to behavioral health. We too, in our capacity with our peers and colleagues from the Colorado Department of Public Health, CDHS, as well as OIT, we have set up regular meetings so that we are all working together to understand and ensure that we are doing the best we can to respond to the questions and inquiries and the trends that we hear from our county partners. None of us can do this alone, and we need all of our systems working together for clients across the state. So we've worked to strengthen that partnership. One of the new partners that we've been working with at the direction of Executive Director Birch is local public health agencies, and really trying to bring them into the picture. We've started to talk with the Colorado Association of Local Public Health Officials to see if there aren't new and creative ways for them to partner with our agency, as well as for them to take advantage of the funding streams that we have available for services. So please stay tuned, and if you have ideas or if you have partners within your community that you think we should be reaching out to, please let us know as well. One of the other pieces that we do, moving on from the counties, is I do tribal relations for the department. So we work with the 2 tribes in Southwest Colorado, and it makes me very happy to see Mary Trujillo Young here, who's currently working for the Southern Ute Indian tribe, but to have somebody who is working with that very unique population have that voice here at this table is extremely important. The department has a seat on the Colorado Commission of Indian Affairs. We are an ex officio member. I represent the department in that capacity, and am also the chair of the Health and Wellness Steering Committee. So there are 4 different committees within the Colorado Commission of Indian Affairs. So within the Health and Wellness, our sister agencies, CDPHE and CDHS, also participate, along with Connect for Health, as well as local public health agencies within the community at the county level, as well as from the tribal level. So it's a way, again, for us to all come together to figure out how we can better serve that unique population. We additionally partner with the Urban Indian organization, so we work with the Denver Indian Center, the Denver Indian Family Resource Center, as well as the Denver Indian Family and Health Services Center. They are an MA site here in Denver, and we, again, are working to get our team out to the site later this month. And I'm also proud to say that we conducted our first ever formal tribal consultation. We as an agency signed an agreement with the 2 tribes back in 2011 that we would do annual consultations. This year in September, we took a team down to Southwest Colorado, 3 days, and we visited both with the Ute Mountain Ute tribe as well as the Southern Ute Indian tribe. We came back with a very long list of action items out of that meeting, but that's the purpose, is for us to be a better partner moving forward. So I think that, again, it's our job is to help bring those messages to the community, as well as to bring the messages back to our department. And we do our best to be as objective as we can in that process, as well as ensuring that our team here also has the ability to get out into communities. So thank you. There are questions.
Ms. Birch?
I just would invite the MSB members, as we do go out and travel, if you have an interest, to join us on one of these visits. It's very powerful. So, for example, these 2 scan for me constantly, and they set up meetings where myself, the insurance commissioner, Director Dika, Director Wolf, we try to go out together in some configurations. So our last visit to the Valley really led us to some pretty significant concerns or updates about heroin use. You can hit a heroin down there for less than $5. It's ridiculous. So it shows up in things like the last 6 Medicaid babies that were born tested, 5 of them were testing positive for all sorts of drugs, which obviously creates enormous implications for our society and for our department and the way we have to work together. So just to reiterate what these 2 do, Christina Wooden will follow up and put together, the work with Stan Hilke, our new CPS, Colorado Public Safety Director. She'll follow up and she'll stage, the different conversations or follow-up that we need to do to talk about what do we need to do to try to spotlight an issue in an area that is, so we get more real time as things are coming up and as they worsen or as they change. So that was just one example. There were lots of questions when we were in the Valley about some of the insurance implications. Walmart is making some major changes down there. They're a huge employer. Now you might be going, what does Walmart have to do with Medicaid? Huge implications for insurance. So these are the kinds of things that I think it's really critical for our Health and Human Services departments to be constantly trolling and aware of and reacting to with all this ACA change. And these guys have been amazing. And they're not only just trying to figure out how we get out incentive payments or contracts with counties, or keep us connected with all the county functions, but also trolling for what are some of the unintended consequences that are happening in this whole Health and Human Services landscape shift. So thank you guys very much.
Ms. Roberts.
Thank you, Mr. President. I have a question regarding the gatekeepers. You were talking about the sheriff's offices, and we cover 6 counties, frontier counties in the northeastern corner of Colorado in my organization. And we have a sheriff who happens to be Phillips County. 2%, I think that's the number 2 highest suicide rate in Colorado. It's, we're small counties, obviously, but he is a gatekeeper. What sort of things are you doing because of the limited numbers of mental health specialists and or services that we have in that particular area? Are you doing particular like suicide prevention meetings and such like with Single Entry Point and Area Agency on Aging and some of the true gatekeepers of the community? I'm just, you're probably doing this, but if not, that's a huge need that I see.
That's definitely someone that's definitely taking place up there, and we help coordinate that any way we can. I think we're really trying to focus primarily initially on making sure that those folks have the coverage they need to gain access to some of those resources that are there. So one of the things we've encouraged the Sheriff's Department of Human Services to do is to work together so that upon release, those folks are already eligible, as opposed to handing someone a brochure saying, go down to your office someday and try and figure out if you're eligible for coverage. So we're really trying to be proactive so that when they're released, they already are eligible for those services, and they're also bringing in the RICOs at the same time and the VHOs to say, okay, now that you're eligible, you know, maybe when your first stops or even before you're out, we sit down and meet with you and set you up with a primary care physician or an agency that can support you based on what those needs are and get that evaluation. So we're really trying to be proactive before those folks are released back.
And we're also working with the communities and willing to travel out to every corner of Colorado if communities would like for us to help facilitate those conversations. Or, you know, we also have templates available that local communities can use to begin this process. And we have had some communities who have asked that we come in to help build those relationships, and that's something that we're more than happy to do.
And specifically in that type of example, and I'm not aware that Northeast, that's not come to my attention yet, but thank you. I'll be following up, and they will too. We will then circle back to the BHO out in that area and say, hey, what are you all doing as far as extra efforts around suicide prevention? I know this came up in Summit County. I had a county commissioner in my office about, you know, what are the contractual parts within our behavioral health contracts, our VHO contracts. VHO is a little tricky because, as you all know, Reggie's Department of Human Services, oversees the community mental health system. So, but we at least can get it elevated kind of back into the right tracks, into somebody's kind of wheelhouse of who's first on this. So you all do serve in that kind of ambassador capacity too, is as you hear about issues in the state, don't hesitate to contact these two so we can then get them into the right arena.
Dr. Young?
Well, and along those lines with CDHS and the crisis money that's coming out and the new crisis grant, it's really important for us to watch that and kind of see how that's then implemented in local communities and make sure that our populations that really need that are able to access those services.
Ms. Riley?
I'm going to direct my comments mostly to Director Birch because I can say that I've been doing this for almost 20 years in working with HIPAA, and there have been some interesting years. And
please don't be now. Please don't be now.
It's interesting, but it isn't necessarily bad. Like fights that went on before. But in all of those years, I think we are in the best position, thanks to your leadership and your designation of these liaisons, to work with counties for us to work collaboratively together, and that HIPAA now has a face out there in counties, in communities, in directors' meetings. I can tell you these folks have no easy job dealing with county directors. We have a lot of diversity in our personalities and in our approaches.
Really?
And when they put their face in the room, it's actually often a case of finally finding someone to yell at. And they have to handle that in a very tactful way and take some of that and try to sift through it and see what is valuable, what is just temper tantrums, and how do we then proceed together to do this. Which means that they come back to your department, often being the messenger of a variety of opinions, some of which your staff may not be so happy to hear. I'm sure they have days where it's like, you won't believe what the counties want now. And I appreciate so much that you don't kill the messenger, because that actually eventually leads to some good community collaboration between counties and communities and your department. So I see their faces at a lot of meetings, so I know they're very busy, and having them in the room really gives us an opportunity to move forward instead of blaming somebody who isn't there. So I appreciate you designated the resources and the people. These are great people to work with us on moving forward in this venture.
Nice job. Question probably for you, Ginny, then. Are in this process, are we doing a better job of finding out what's working in certain counties and transferring that to others, or sharing what's working, and so not every county has to recreate the wheel, do you feel?
Yes, I think we are, and I think they're the major messengers to pass it on to the other counties when they go to their regional meetings. And in Larimer, we did a complete redesign of our eligibility system, eligibility determination system, because we weren't meeting our performance requirements, and our staff were frying. We were having a great deal of turnover. People were just too stressed about the way we did things. And we started this a number of years ago, but then in the last year we really perfected it and made major changes. And they have passed the word about what we're doing, because we're now meeting our performance requirements, and as Mike said, probably one of the best in the state for doing that. And so we have been swamped with visitors from other counties to look at what we're doing, including Mesa has been out to see us and talked about potentially buying our workload tracking system. And so they're the ones, more than me talking about it, because when I talk about it, it's all, Larimer this, Larimer that. We're sick of hearing about Larimer. But when they talk about it, it generates the interest. So
great.
They are the major conduit for getting that done, not just in eligibility, but in a lot of other areas.
That's great.
We are doing, thanks to our discussions with them, doing a partnership with a criminal justice system in Larimer to do eligibility determination before people are released. So
it seems so basic, but it isn't, and so really appreciate the work that you're all doing to help those communication lines. Any other? Yes.
I just want to also echo a lot of what Jeannie said, and we truly appreciate the invitation to the consultations that you had with the tribes, because we're also trying to work with them and make sure that there are no gaps as far as health coverage. So again, that appreciation of that, bringing that partnership to the table as you travel, throughout the state, and especially with the tribe. So again, thank you.
Anything else? Yes.
One other comment. It was nice when you did the tribal consultation and that DHS was also represented there, because that's been really appreciated, because there's so much overlap, especially, speaking for myself, with behavioral health, and having a smooth way to talk with both departments and knowing that you all are talking to, I think has been really helpful, and it's really noticeable. Thanks.
Well, I think that really goes to our leadership. As Sue mentioned, she and Reggie and Larry and Marguerite meet regularly, and we do what we can then to continue that partnership at all levels of the organization. And so, it's with our partners that we're able to continue to strengthen that collaboration.
It's working.
It is. Keep it up.
Don't mess with it.
Stay on the road.
We'll be at the lobby selling the tickets to the 2 o'clock tour of Larimer County.
Perfect.
I hear that goes to the beer factory.
8 or 9 microbreweries.
Absolutely. Great.
But in all seriousness, though, if you would like for us to work to schedule a site visit to your community, to work with your organization and your partners, please let us know. I know that we're always looking for different venues to visit, which would primarily be in the spring and summer of next year, post-legislative session. Director Birch oftentimes gets called over to the Golden Dome at various times, so if you want us to come, let us know.
Great. Thank you both very much for everything that you do in your presentation. Appreciate that. Last but not least on the agenda, Sue Birch with the department update.
So I'll try to be short, but because I know we're getting late into the morning, but it is great to be back. You can imagine after the last few weeks, it was definitely a little stressful. So we are thrilled this election is behind us. You know, this is an administration all about collaboration, and so we are ready to fire up for a second term on the same kind of spirit of working together and collaborative tone. So I do want you all to know that you play such a key role in being our eyes and ears and giving us tough feedback and pushing us to courageously go into some of those counties where we know we're going to be absolutely ambushed. Well, you always tip us off early, but we will continue in this same sort of process. So it is really incumbent upon you to bring us kind of, we like to hear the good comments first, but also we like to get the feedback of where we're challenged or where we've got problems. And I really encourage you, if you have any interest at all, to travel with the departments as we go out, to just get on, let me know or let Ellie know or let Judy know, because we do, I think it would be fine. I know Mary's been, Mike, you've seen us in action, Brenda, you've seen us in action, but it's really worth it to go out on some of these county visits. And it's not just local counties. We also now drive a lot of the medical community and the healthcare community, the RICOs, to come together with us when we go out, because, you know, we're helping people understand this, you know, this commitment to not only health but well-being. So anyways, it's really fun that we get to kind of refresh, and you will be hearing lots more in the second term about health, wellness, and prevention. This ongoing tri-agency work is only going to accelerate. And Mike was so kind to join me this morning to go to the launch of the presentation for this report. Judy, we're going to make sure these guys get the, I'm pointing to Tim for you on the phone, I'm pointing to this new report out, Measuring Behavioral Health, Fulfilling Colorado's Commitment to Becoming the Healthiest State. And here's what I want to tell you. I think this is the most exciting, like, quote in here, although this is from the State of the Health, but it's so important we put it in this report too. But imagine this, if Colorado ranked #1 among other states in mental health, nearly 93,000 fewer Coloradans would suffer from poor mental health, and Colorado employers and employees could save $121.1 million in annual healthcare costs. This is just one dimension of what we are trying to do with our realigned work. But I tell you that because this one is kind of a front runner. It's a showcase of this work and how powerful it is if we align and do our work not just in the physical health kind of medical setting, in the traditional way we think about things, which we have to keep doing, but we have to start pulling in all these other social supports. And so the report is fabulous, where they talk about the metrics. And this work is being really showcased nationally, because you'll see more reports like this coming out, really sharpening kind of the emphasis, the best of what each of the departments has, the 3 departments, the best of their work, bringing it together and really then substantiating kind of the cost savings and how we're driving value. So please, we'll send you this, and I think it's really worth, if you have insomnia, you can read it, but it's worth a quick glance or read so you can better understand what is she up to, or what are they up to together. But that's really exciting. But let's just talk about some of the other things that are happening right now that are really important. So I know you all had a sneak peek at the shared eligibility system, but it is live. We are not getting complaints. We are only getting accolades. We believe we might be #1 in the country here pretty soon on creating the best system, which really, when you think about 4 years ago when we came in, I just still can't believe where we've come with CDMS, and still have to kind of go, wow, we did it. It's going to greatly improve customer experience. It's more dynamic. It's a single application, so people don't have to do this, like, redundancy. We lead the nation right now in real-time eligibility. This is fabulous, except it will create problems for us for the future. So 70 to 80% of the time, if you go on with your stuff, all your necessary ID information, you will get a real-time eligibility in 45-ish minutes. Used to take 45 days, everybody. But what's going to happen, and so we have to get ready for this, is in the years to come, our counties will not be paper pushers anymore. And so we have to get ready at retooling that workforce to take on different types of realities. And they're already reshaping this, but we have to pay close attention to this reshaping. Because this real-time eligibility will, and it's great because we want our clients to get more empowered with their own care and well-being. And so this is that first step of what I call new consumerism. And I know I've had this talk with you before, but but aligning kind of their sign-on functionality and aligning kind of their understanding of what copays are, or what system are they in? Are they in a public system, and will they churn over into a private system, and what happens when they go back, and how do they work? What do they need to know about a member card? And all of this work between us and Connect for Health and the counties is all really important base that we have to keep laying. So open enrollment starts next Saturday, or this Saturday. This Saturday, I'm sorry. And you all also serve a huge role in this, and I'm really proud that we mobilize nurses and doctors in our state about, hey, ACA basics are this, and they played a huge role, and I can't help but believe that all of us turning to our neighbors when they say, oh, I'm uninsured, and saying, wait, how can that be? We've got Connect for Health, and or have gone to Peak. You all play a huge role in that. So I remind you that, and Brent's going to correct me if I've got anything wrong, but we run from November 15th through February 15th on the exchange, 3 months this year instead of 6 months. So now, and I have 3 wonderful children, adult children, but I always have to remind them, don't wait till the last minute, don't be a procrastinator. But since we're going from 6 months to 3 months, there's great potential that our systems are going to be overloaded even more, especially for our procrastinators. So we really want to get people in now. They need to sign up by December 15th. They have to pay their first premium by December 25th. The carriers will be accepting payments on Christmas Day. And we do expect a pretty big influx of people, because in Colorado there is this huge compassion push for get covered, that's the norm. And so we know that plays out in things like what some people call woodwork effect and whatnot, but it also means that we're much more successful too of finding our eligibles but not enrolled, especially kids. There should be no kid in Colorado that isn't covered in some way. And we really, you guys, I'm not kidding, play a huge role in this with us. So, yes, we're a kind of superstar in the state, in the country. We're in the top 5 best for finding people and getting them covered, but let's go right to the top and get this done, and let's really concentrate then on making sure people get the right kind of Medicaid experience. And our Accountable Care Collaborative is really getting a very thorough look over now by all sorts of evaluators, because it's been so successful. We just remind you about some of these successes. 30-day hospital readmissions. Our members without disabilities who were enrolled in our Accountable Care Collaborative for more than 6 months had approximately 33% fewer readmissions to the hospital. And that's compared to those that are not enrolled in the ACC. And so you can see why it's really important for us to drive as many people into our framework, into that ACC framework. It saves us lots of money. And high-cost imaging. Adults without disabilities enrolled in the Accountable Care Collaborative more than 6 months had approximately 35% fewer imaging services than those that were not enrolled. Children without disabilities had about 19% fewer imaging services, and the performance on this metric over the last 3 years has been so strong that we're actually going to move on to the new pay for performance metric. We want to give a new challenge to the RICOs, but that is just one domain. That's one of those key performance indicators, and you'll hear in a minute how this translates into dollars. Emergency room utilization. Again, and this applies to people that have been with us more than 6 months. But those on our ACC framework use the emergency room services about 8% less than those that were not enrolled. And our well child visits, about half of all of our kids under the age of 18 received a well child visit during 2013 and 14, and we really want to embrace that target and improve that one. That key performance indicators, I just came from a meeting this morning with Children's and the university about what we're really going to do to try to accelerate on meeting the mark in well child care. So for most populations and indicators, the utilization increased during the first 6 months of enrollment, and then it decreased once they get onboarded and they get kind of settled into our new service delivery patterns. And we are mirroring kind of nationwide utilization trends for populations gaining new or better access to health care with our expansion populations. But truly, our framework, our accountable care framework is changing the way Colorado is delivering up healthcare, and we're seeing more movement from our private carrier partners with their involvement with the Comprehensive Primary Care Initiative, and more alignment. And you'll see more of this with our SIM grant, which we are negotiating with our federal partners right now. We're down to talking dollars, and we won't be announcing anything publicly until we have final word. But it is really important for you all to be able to explain to people that this is not just the same old type of Medicaid. We're integrating, we're collaborating within our service delivery areas, and we're starting to pay for things in a completely different way. So you know that our Accountable Care Collaborative now covers more than 70% of our Medicaid clients. That's a huge number, that 700,000 number that Jed talked about. And we're going to try to take that right up to 97% of our Medicaid folks in these care coordinated environments. We have to have an opt-out. People have to be able to say, I just want to do straight fee for service or not be in that kind of care, but we really want to see it be kind of our primary service platform. We did release a report to the Joint Budget Committee talking about the gross savings, well over $100 million off of this year's ACC successes, and that will only strengthen as we get more and more fully loaded into the ACC framework. So huge, huge shifts with this type of work, and I get stopped by all sorts of physicians and care providers who have said, gosh, you guys are making this back to kind of the kind of healthcare that we signed on for, and working together in teams, team-based care, really important. And of course, we're always beat up on pay us more. And I remind people, we're not going to be paying more. We're going to be redistributing the dollars and incenting the things for value, incenting the services that drive value, not volume. So it is an exciting time because lots of change, lots of confusion about what that means, lots of, wait a minute, why would we be concerned about supportive housing, or why would we be concerned about some of these other things that aren't traditional medical? And we know that they will boost our work and accelerate kind of the value proposition. So with that, I will also tell you that on November 1st, we transitioned to a new non-emergency medical transportation vendor, and this is a very good example of oftentimes, you know, we need to be able to get people to the services that they need, and we have to make sure that that work gets done in a cost-effective way. Our new broker is an entity called Total Transit. And so far, it's going well. There's a few minor scheduling issues, but there's the transition has really been much smoother than in 2012. But as you hear about things, please let us know.
What kind of region do they cover?
It's a 9-county Front Range area, the 9 Front Range counties. And I don't have those counties, but I can get them for you. But it is not on the western slope. We're keeping the same phone number and website the same, and it's really been much better for the consumer. And but we know transportation is an ongoing issue. It's a significant driver in our budget. So please, as you hear things, direct that back to me. So I also want to just say that the work of getting people on, getting them into a new type of system is evolving. But you'll see a lot of really exciting future work, and I'd like to just talk a little bit about that ongoing kind of future work, the future landscape that we've got to keep living in. These culture shifts, I keep describing them as culture shifts. You know, the first one was, it was no longer that, you know, it was no longer of, are you insured? It's like everybody needs to get insured, and what kind of coverage do you have? Since we seem to have tackled coverage in most parts, knock on wood, I'm challenging everybody in the state, let's get 90% of people covered after this next enrollment period. But I think the next big thing that we're going to see transforming is more of this client-centeredness, more of this, what do our clients want, and then how do we respectfully deliver within constraints or kind of the reasonableness. And I think we can really do a lot better by using IT. So we've got some very innovative health information technology upgrades that are happening. As you know, CBMS was our first success, MMIS is our next success. I think the third big one you'll be hearing about is Project Echo. And we'll be back to, I think you've heard a little bit about this virtual grand rounds, this demonopolizing of knowledge, this specialty care enhancement that we are pushing for. But you'll see more and more about innovative IT. You'll also see more and more about public health involvement. You saw the budget request to really drive our public health partners to the table. It really means Christina and Mike have the challenge, and you heard from them how they're trying to reach out and bring our public health partners closer in, because we know in this Medicaid world, and you guys know all too well from sitting here in your seats on the MSB, that we don't just have to drive good individual health outcomes, but we have to really pay attention to population health outcomes. And so where we are already prone to have health disparities and inequality, we've got to really target and work on how you level that. And so bringing our public health partners closer in on this work is really important, because it doesn't really matter anymore about coverage, because everybody's going to be covered. And so we want population health on both the commercial side and the public sides, private and public working together on population health. You're here, we're seeing it already. We're seeing it through things like the new health neighborhoods that are being launched. We're seeing some very exciting built environment projects crop up around the state, where neighborhoods are being designed with more paths and more push towards community gardens and more blended housing, supportive housing. And that drives more team-based care, and that means the department here has to reignite its work around workforce redesign. And you'll see us partnering more and more with DORA and Division of Insurance. Kate Kiefert from the Governor's Office and Chris Underwood have really ignited a team around the next series of requests we make to our federal partners about more IT solutions. And you know, between 2011 and 2015, we implemented kind of a phased strategy for adoption and widespread use of our health information technologies. But we'll have another very large request going into our federal partners about taking that to the next level. And these statewide improvements will ripple out over to Reggie's department and to Larry's as we look at how we want to create more value and what are the necessary data sets that we need to have access to and use, so that we can really, again, figure out what's the root challenge, what's the root cause of a problem, and then how do we go after tackling it. And so we know data sharing and we know data analysis is really going to be important. So think of this like kind of the electronic health records convergence, the health information exchanges converging. Think of it like some of the telehealth areas that have to be modernized and strengthened. Think of it like all of these things coming together and transforming to be much more successful. And our long-term strategy about this is going to be to continue to fuel the provider adoption of electronic health records and all the full range of the health data opportunities. So just as a very real example of this, off of our MMIS system, we have the ability to have a very robust care management tool. And wouldn't it be interesting if every single entity that bills us, and I remind you, we put out about 100 to 110 million a week on the street, but imagine if they were all working off a common care management tool. We have that ability now, or soon, but we are building these things in. Imagine, as you heard from today, if we really got our clients to use their own personal health records so that they could kind of know where they are in their individual health plan. I, for one, got sucked in probably a year ago into Cafe Wellness State System with my Fitbit, and man, I try to get my steps and pay attention to what my own personal health plan is. And imagine if we could really get our clients more encouraged to have more skin in this game, and that's what we're driving for. And we have to get federal approval on some of these things because it's not so easy. And I don't mean that just in mobility. It could be just on maintaining your stress level or maintaining control of your consumer-directed clients. It could be whatever it is to help you be at your peak for whatever life condition you're at. So I don't want people to think, well, you know, this is just the department's way to cater to the able-bodied. It's for all populations. And so we really want to challenge our clients to really get more involved in this person-centeredness approach, and they are loving it. We want to link the IT adoptions and demonstrate significant quality improvements. We already know that our private carriers have quality ratings for their providers, and they try to narrow their networks and only go with their 5-star quality providers. We want all of our providers that are taking our clients to show that they already have some base in practice transformation of quality focus, and many of them are already deep into this quality game. But we want to demonstrate that we've got kind of that level playing field of quality amongst our Medicaid service providers as well. And obviously all of this has to have great attention to our most vulnerable. And we really know that you can't do this work just in the pick-puff Medicaid silo, that you really have to partner this over to these sister agencies. Reggie's really struggling with bringing up electronic health record systems in his hospitals. We need those systems to be in place so that we really have a good grip on care and coordination and costs and whatnot. So we will stay totally committed to the, I say tri-agency, but it's really quad-agency because DORA has come into play so much more. We know that there's only so much time, though, so we will be coming back at you as the administration really focuses on some of the big lifts that we're going after collectively. I'll be updating you on those, but we're really carrying forward with this work of the State of Health Plan, because much of this is in the Governor's State of Health Plan, but we're kind of refreshing in the workforce arena and renewing with more of the IT developments, and certainly trying to drive as much of this public-private partnership as possible. I want to tell you all, too, that in January you will be coming to the first ever tri-agency board meeting. So between the 3 departments, we are getting all the boards together to kind of have the same sort of discussion about this is where we're each at and what we're going after, so that people can kind of see how these things are crystallizing together. And Judy and her counterparts at the other departments are trying to wrangle that meeting together, but it should be really great. And I think it's really cool that it'll be the first time ever in the state of Colorado's history that we're bringing the 3 boards together just to visit and understand what each of these 3 domains are doing and how this work collectively together really fuses and transforms what we're doing. So we're going Godspeed forward in healthcare reform. We're embracing the good parts. We're working around the bad parts, and we're driving a value proposition for this state. We get it that we can't consume more and more of the general fund. We're excited about the challenge. Yeah, I'm ready for the next 4 years of going forward, and I got a tremendous staff and couldn't do it without them because they really do all the work. And I know you guys play an enormous role, too, in kind of level setting us or checking us, too, when we're off, and also serving as our dignitaries. So thank you for that, and you know you can reach out to me anytime, and I so appreciate that we get together quarterly, but every month I get kind of a refresh of what's going on, so.
Great.
Questions for me?
Questions. Ms. Riley.
I have 2 things. One is that I signed up for a national webinar that Sue Birch is going to be one of the participants in, on the panel, members of the panel.
What is that?
I wondered if you might want to tell them in case anyone else would be interested in it. It's a free webinar.
Is this from Governing Magazine?
Mm-hmm.
Okay. Yeah, so we were just in DC a few weeks ago actually doing that live. I think they wanted us to demonstrate, but it's about this integration of health and human services and how, again, you guys, I know you're sick of hearing this from me, but we can't, and I know sometimes my medical counterparts shrug when I say this, but we can't over-medicalize, and we have to bring up the well-being part of what we're doing for our folks, especially our most vulnerable. And so the talk is all about health and well-being and how we drive forward, how we get our federal partners to allow this convergence of good evidence-based health services, great evidence-based health services, but also great evidence-based social type services. And when you put those 2 together, the nexus, the intersection of that work is really extraordinary, and that's what the talk is about. So.
My second
can try to get that out. I think that's what it's about, but there might be
yeah,
others.
it's the Governing Magazine.
That's great.
Yeah.
And my second one, okay, now that I buttered you up,
Tear you down.
is the ask. We have a partner organization in Larimer County, the Health District of Northern Colorado, who has been trying to be an MA site for quite a few years, and the department has not been considering new MA sites for quite a few years, and I just want to encourage you that with the tidal wave that's coming our way, and they are very competent and qualified to do this. Right now, they're an application assistance site, so that's all they can do, but they really do have the capacity and the ability to be an MA site and help provide some relief to our county. So I want to encourage you that the department open up that process.
Thank you. Again, I know there's old rubric and old conditions and kind of old paradigms, and as all of this has gotten simplified and streamlined, what does that mean and how do we shift? And I will absolutely go back and be visiting with my team. That's not the only side of the state that's kind of asking us to revisit this issue. So thank you for that, and I will be looking into that, Jamie, and I'll get back to you.
And if you want to let me know who those other people are that are pressing you, we could pick it outside your office or something.
We don't like pickets, but you can do what you want, but we'll get back to you.
Just kidding. Thank you.
Anything else from the board? Otherwise, we'll see you all in December. Thank you very much. We're adjourned.
Thank you.
How's that?
Stay warm.
Times.
Happy